Welcome back, everybody. Welcome back from an intense day and a rich afternoon. You can relax during this part of the program for the next hour. We're going to do two things with you all today. We want to get some feedback before you leave about how the day went and how we can improve the second and third day. There's an evaluation form, on your table, which you will be asked to fill out at the end. The second thing we want to do with you is to have an executive team from CMS coach you in how to respond to Dr. Berwick's request, and specifically how to respond to the panel that's going to be put together for you to talk to on Thursday. So this should be kind of an exciting moment for all of us, because what we're going to be playing with is a rather profound question. How do you respond to a leadership request? By the way, my name is John Scanlon. I'm a consultant who works with executive teams in transition. So it was exciting to me to be in the room with you this morning and hear Dr. Berwick make a leadership request to a group of people who he called a change agent, a sea of change agents. How did that make you feel? Do you all feel like change agents? How many of you felt like that when you heard that? How many of you put that? That's kind of an exciting. Imagine a national leader in conversation with a room full of change leaders, change agents. How many of you actually heard Dr. Berwick make a leadership request? Raise your hand. How many of you actually heard him make a request? Put your hand way up. How many? Did you? About half the room. How many of you who heard it thought that he was talking to you personally? Raise your hand. About a third of the room. Well, I'm going to make a request. I'm going to go over what Dr. Berwick said briefly and give you kind of what I heard. And I'm going to ask you all to take Don Berwick's request as personal, that he was talking to each and every one of you personally. And I want you to set aside, just for this exercise this afternoon, your organizational affiliation. We're not talking about your organization doing this. We're talking about the leadership request that Don Berwick made to you all personally. Does that work for you? See how this goes when we play with this for the next half hour. The request he made was very bold and rich. He wants you to partner with CMS on bold national goals. Boy, there's a lot loaded into that, because then he talked for a good half hour about what he meant by bold national goals. And look at the language he used. We are not seeking incremental progress. We are not seeking the predictable aims. He talked about we don't want the status quo to be repackaged. We want the whole system to change. And when someone tells you this is disruptive change, there's a signal that you're in for a little trouble. Disruptive change means your life is going to be disrupted a little, because you've got everything kind of planned going forward, and now that's going to be throwing a curve at you, and it's going to be a little disruptive. We are seeking breakthrough progress. Remember he said no more 1% change? We were after 50% change. We want to do it rapid, quick, breakthroughs. He said, I want you to lead. I want you to help with these national goals. And as someone who works with executive teams and helps put their agendas together, this was the first time I heard Don Berwick talk about this, but here are the kind of goals that I think you could expect from a person like Don Berwick. He's talking about 50%, big changes, like 40% reduction in healthcare required conditions, one of the priorities, 20% reduction in hospital readmissions. I put down a third one that's more proactive than reducing. It's more growing than 1 million hearts protected, by the aspirin, blood pressure, cholesterol control, smoking cessation initiative. Those are the kind of bold goals that Don Berwick is asking us to lead with him on. He's talking about if your region or your state is successful on these goals and it all adds up, the nation will have these breakthroughs in quality and performance. It's pretty exciting stuff. He's serious about this, so much so that he said, we were not going to be telling you a lot. We want you to tell us. So he's putting together an executive panel led by Joe McGann on Thursday for you all to come into a room like this and tell them what is your response to Dr. Berwick. Now, when a leader makes a request like that, it's not exactly obvious what your response should be. And so I thought I would give you a little construct, a distinction that I found very valuable in working with leadership groups. And that distinction is the distinction between accountability and responsibility. Because in a sense, that's what Berwick's conversation with you is. It's about a different kind of accountability. Well, I'll come back to that later. These two terms, how many people think these mean the same thing? Raise your hand. You think they're different? Most people think they're different. I always thought they were the same thing. And about 15 years ago, I was listening to an executive who was a former CIA official who went to TRW and became an executive vice president. And he was telling a group of federal officials about a defining moment in his life at TRW where he found himself accountable for delivering a weapon system, but he said he didn't have the responsibility he needed to deliver it. And so this looked like a crisis, for his organization. It could really affect its ability to survive. And he used these two words differently throughout his talk. He kept talking about he has an accountability to deliver something by a certain date, but he doesn't have the responsibility he needs to do it. And it turned out he was making a very profound statement about the difference between these two things. He used responsibility to mean things that respond to me. So there are things that you control, that you have ownership of, sort of like your budget, your staff, things that your sort of peer relationships, people who will do things that you ask them to do. And the accountability is a little different than that. It says these are the results you deliver to someone at a given time. It's sort of countable. It's a result independent of the activity that you deliver. And it turns out you can take these two concepts and start to distinguish different kinds of accountability conversations that people want to have. If you set them up, one of the accountability conversations that we're all familiar with is the manager conversation, where a manager is both accountable and responsible. A manager has some outcome, some result they have to deliver, and they have all of the resources they need, usually, to deliver it. In fact, that's the mark of a great manager. They really work hard to make sure they can always deliver what they promise, that they have the responsibility in place to make that happen. Now, in organizations, we encounter another kind of role that's often in place, and that's that of the supervisor or administrator, where you're responsible for getting a process to operate a certain way. It's a responsibility for regulations being followed, for protocols being followed, and the administrator is responsible, but usually is not accountable for the results of the operation. Does that make sense? In a sense, the administrator makes the buses run on time, makes the airplanes run on time. The administrative function makes sure that every time you go to the McDonald's in the morning, you can get an Egg McMuffin. And in fact, the manager, on the other hand, is responsible for what comes out the other end. And I did some work years ago with a home builder outside of Philadelphia, and you go to a home building site that he ran, there would be hundreds of homes being put up, single-family townhouses in a development. And it was always amazing to watch the project manager, because there would be a dozen homes on different levels of being built, and there were hundreds of contractors all over the place. And Don Berwick this morning said, if the system isn't working, you don't want to yell at it. These managers made their system work by yelling. There was often yelling going on where the manager of the building site was trying to get the contractors to do the right thing. And I remember one where he was screaming at a contractor, how could you have put blue toilets in buildings where all the other fixtures were white? And he said, didn't you look around? And of course the answer was, well, the form said that I should put a blue toilet in there. So the manager had to deliver livable houses that could pass inspection, that the customer would buy off on by a date. And so a manager had all of the means to make that happen generally, and that was a sign of a good manager. Now there's another level here where we're going to put the leader in, and the leader is by definition accountable but not responsible. This was the Bob Kohler problem at TRW. He was accountable, but he didn't have the responsibility he needed to deliver. In fact, the leader, what distinguishes the leader is finding him or herself in that place and still owning the accountability. They still say that they're personally accountable for some reason for the goal. So what does a leader do if they're accountable, but they find themselves, they don't have the responsibility they need? What do? What does a leader do in that case? We know what a manager does. We know what an administrator does. What does the leader do? Shout it out. What do they do? What's that? They get others involved? Persuade others? Very good. Persuade others. Energize others. Inspire. Very good. Any others? Start over. Yeah, you're really getting what a leader has to do is go make deals, enroll other people, inspire, get them excited to join the effort, and bring other people's responsibilities to bear. Once they get sufficient partners and alliances in place, then they can go back to managing and administrating. But a leader has to go off and start to see what the possibilities are out there. And a leader, when they do that, often does not know where they are. So he'll start to make requests like Don Berwick did today, and he doesn't know what's going to come forward, where the new solutions are, where the breakthroughs are. But that's what the leader does. They start to create a space where that can happen. So we can go back to that question now. How do you respond to a leadership request? This isn't a conversation about statements of work or contracts. That's a management question. What are you going to manage on? What's the budget I need? The leader is really asking you to enroll with him in this new campaign to achieve really bold goals. Now, when you respond, the response can be a little scary. When you see Don Berwick in front of you asking, it might be easier to say, he's really not talking to me, he's talking to my boss, or he's talking to the table over there. But if he's talking to you, you should get nervous. Here's what it feels like when you're kind of reacting to a leader. It's that moment of panic. Is there a safety net there? Who made this rope? Who's holding the rope? And could I fail? Because remember, you've got your life in order, you know what you're doing, your people have hired you because you're a great manager, a great professional, you've got years of experience. All of a sudden, you're faced with something that you may not be able to deliver on. In fact, it looks like that. And what the danger is in responding to something like Don Berwick's request, you may be kind of driven back to the management mindset or the administrator mindset where something you're comfortable with. Because as a manager or an administrator, you want to keep things under control. I've got to get another picture of management because I love management and this doesn't quite do it. But you want things under control. You want to know what's going on. And like we said, as a leader, when you step forward as a leader, you're not quite sure what's going to happen. They say you don't know what you don't know. And you're creating a space to create opportunities and possibilities. How do you respond to a leadership request? Here are 3 ways you don't respond. First of all, you don't argue. Because it's nothing to argue about. Someone's telling you, I have a vision where we have 40% improvements in healthcare required conditions. That's my vision. I think we can do it. Could you join me? It's not an thing to argue about. You don't say that you're going to need to go hire 120 staff. There is a way to get those 120 staff, but it's not by hiring them. It's by getting other organizations to partner with you to put their staffs in play with you. So it's not a management conversation. You will have management conversations, you will have contract conversations, but this is a leadership conversation. Also, you don't want to just sit there and look at him and say, well, he's really talking to somebody else, hopefully. He's really talking to you. So we found out that in working with leadership teams for years, that there really is a neat way to respond. And I'll give it to you. There are 3 kinds of responses you can have. You can address the leader and say, the request coming at you and say, I am willing to co-lead. In our region or in our state, I will stand for that goal, and I will be your person in that area, and I'll make it happen. Does that make sense? You can co-lead. You can offer to co-lead. As a matter of fact, as a co-leader, you can even make requests back on the kind of objectives you would like to see added. The second one says, this is great. I can't co-lead at this moment for whatever reason, but I love what you're doing and I'll align with it. That means my organization has meetings that you can attend and use. We have data I can make available. We do a lot of things, and I will find any way you want or can come up with to ways to help you. But I can't be in a leadership role. And the final one says, acknowledge and pass. You might say, at this point in time, I just can't get involved, but thank God you're doing it. Thank God somebody is doing this. I'm going to root for you from the sidelines, and maybe in the future I can align or co-lead with you, but right now I want to pass. I'm going to pass. Now, you notice there is no 4th one, which says, I oppose this. We used to have it there when we work with teams. But in the 15 years of doing this, we've never had a situation came up where the goal and play was drop dead opposed by the people in the room. Because it turns out you've all been working together for years. You're very far along in your careers and your professions at the top of it. You really know what should be done, and you are in agreement. Now, you might argue about it, no doubt. We call it being in violent agreement. But you basically all agree. And so these are the three primary responses that we think really make the conversations with a leader very powerful. And so with that in mind, we're going to suggest and help you through a little exercise. We're going to practice for Thursday's CMS Executive Panel. This is a panel of leaders that you're going to have access to. And you'll notice on your table, there is a 60-second leadership story response to requests made by Donald Berwick. In a moment, we're going to ask you to fill this out, and then we'll ask for volunteers to share. But I'm going to walk you through it, and I'm going to ask another CMS executive panel, just as good as the one on Thursday, but different, to come up and coach you on what we mean by this 60-second leadership story. And then they'll also hear your responses later after you have a few minutes to work on it. So with that, I'll ask my panel to come up. Jean Moody Williams, Deborah Hattery, Dennis Wagner, and Paul McGann.
It's like packaged for CD or formatted for CD and copied the whole folder.
2 mic runners.
Okay. You'll notice this form, this 60-second leadership story. Do you all have that? You all have it? That 60-second has 2 parts to it. It has a statement of goals, bold goals, which are the kind of things that Don Burrick wants to be in partnership with you. And it also then has what we're calling readiness statements, 7 readiness statements, which when you fill them out, you will realize you are ready to do this kind of work. They're very simple things. You are more than ready to play leadership roles in this nation with Don Berwick and CMS. So the first part we're going to ask you to do is check off one of these goals. You notice I put pass for the moment, so you might want to do that. But I'd really suggest that you pick one of the first 3 just for this exercise to feel what it's like to actually say, yes, I want to co-lead or align. So be in action in a positive way. In fact, this is really kind of serious stuff for the panel you're going to talk to on Thursday. They want to hear bold goals from you. So, Jean, would you like to kind of comment on these goals in the panel on Thursday?
Sure. I think what you just said, this is serious stuff, and that couldn't be more true. We have an opportunity because they do really want to hear from you. They are in a position of making bold change in this country. And they've realized, and Don said it, that they can't do it alone. Not just for the 10th Statement of Work, which we've talked a lot about, or the ESRD redesign, which we've talked a lot about, but there are many other things going on within CMS and the department. And the information that's provided will help with that. For example, the National Quality Strategy is underway. The CMS priorities are being developed. The HHS strategy is being developed. There are White House initiatives that depend on bold goals. So when they come seeking the answers to the questions or to hear what you expect, they really are honestly looking for your responses, and we'll use them, believe me, as they move forward.
Beautiful. So the beginning of the script, this is a script for your story to the panel, begins with, here is the bold goal, here is an example of a bold goal we're ready to be in action on. And that's going to really excite Don Berwick and that panel. Then we talk about readiness expressions, and these are statements you can make that really show that you are ready to be in action to make those goals happen. And one of them, the first one, it says, of the two of the most important partnerships we would have to create to realize this goal are. And remember, a leader generally gets work done by creating partnerships and alliances. And all of you are exquisitely positioned in your state or your region. You know all the players. You've been with them. You know how to get them on board and enrolled. Let me ask Paul, well, there's one other. There's a second side to this, by the way. Not only are the partners out there, but you are a great partner. You are a very attractive partner. Because of the work you've done over the last 20, 25, 15 years, you've built up all kinds of powerful assets that allow you to really be very attractive to an alliance. People want to come and work with you because you have assets. But what are the assets you're most excited about? So let me ask Paul, how would you like to react to what you're hearing with the idea of the partnerships and co-equal partnerships here?
Thanks, John. So I think there's a great list on your sheet here, and you should think of each of these things carefully. But the 2 that John started with, partnerships, and then we're going to slide from them into assets in a broader sense, are 2, I think, of the most fundamental things that our program has learned over the last 4 to 5 years. And I can think of any number of examples of this, but I'll just take a couple. I just came actually from the sort of wind-up session of the high point evaluation of subnational theme 7.1, reducing healthcare disparities, which, as you all know, is diabetes self-management training. And the energy in that room was palpable. And we had the luxury of time in that session to kind of trace the history of this, which actually goes back more than 3 years. And we all reflected on how many Medicare beneficiaries we had exposed to this life-saving, evidence-based treatment, diabetes health management training. And we were able, many of us in the room, to reflect on what it was like back in 2008 and even 2007. And we asked ourselves, as a QIO alone in those initial contracts, how many beneficiaries could we reach? And the answer, when we asked that question then, was measured in hundreds. And then as we got more sophisticated and Mr. King generated more revenue and we were able to spread to Tennessee and then to Mississippi and most recently to Texas, what we saw is for less amount of money than we started with, people were able to realize outcomes that were orders of magnitude larger. So we started with hundreds, we went to 1,000 or 2,000, and in this latest manifestation of the same contract for less money, we're talking about reaching tens of thousands of Medicare beneficiaries with diabetes. And Mr. King challenged the group to think at the next level up, which is millions of beneficiaries. Now, how is that possible without throwing more money at it? And the answer is that Section A, partnerships. And we're not here to talk about all the many partnerships of the diabetes program, but things like AADE, the Association of Diabetes Educators, the American Diabetes Association, the Administration on Aging, the Office of Minority Health, the local state health departments. And you should really, if you're not familiar with this project, talk to the people that ran it during the night scope of work, because I think it's one of the best illustrations of this partnership we see. Another example is in the care transitions field, where we reached out not as a readmission project for hospitals alone, as we may have in the past, but we brought in home health agencies, we brought in other types of community providers, even ambulance services and physician leaders in the community. Again, great results through partnerships. Now, John said, well, what does that mean about powerful assets? Like, why are you even using the word asset? And we're using the word asset for a very specific reason. We met earlier today with Dr. Straub and the CEOs of all your organizations. And I've been with the program for 10 years, and I've seen this conversation more than 100 times. When Dr. Berwick and John and Dennis and Tara start saying 20% readmission reduction in 1 or 2 or 3 years, 40% or 50% reduction in health-acquired infections, you all know the numbers and targets of the night scope better than anyone. And the initial human reaction is to say that's just not possible. And the question of asset comes out immediately from a CEO. And what asset will they talk about? Money. It's the asset that we talk about in the United States. But what this question is asking you to do, and what we all need to do as a group, and we're here to help you with this, is before we appear before the executive panel that controls a lot of the assets at CMS on Thursday at this conference, we need to broaden our understanding of what assets are. Those partnerships I just went over with you, AADE, ADA, State Health Department, AOA, those are assets. You know what else are assets? This is an asset right here. This man who just joined us, he's an asset. He brings skills and experience that many of us at CMS before Dennis arrived had never even dreamed about. That's an asset. You know what else is an asset? Tracy Archibald, who won the Director's Award earlier today, is an asset. What else is an asset? I have a book on my desk right now that Tracy and her team were able to get me that calculates the 30-day Medicare readmission rate for all 5,000 hospitals in the United States. Now, normally we'd sit down and we'd argue, and someone would say, but they're not risk adjusted, and how can you use numbers like that? I use numbers like that every day, and I can tell you after the conference how. That book is an asset, that information and that data. We need to think carefully, John, all of us, about assets and expand our vision of what the assets are that we have access to. That's what the executives want to hear on Thursday.
Beautiful. Thank you, Paul. C and D are related. One of the things that you really have to bring to the table are change methods. Like, how do you get every hospital in your state or region to work on readmissions. That requires a methodology. And you do have change methods that you've been practicing for years and have mastered in a lot of different forms. And those come together with evidence-based practices. Don Berwick said, we know how to do these things because we can go to a health system that's doing it. So we have models that work that we can deploy in very powerful change methods. Let me turn to Debbie. Deborah, how would you like to respond to those?
Well, a little bit in character here. I'm going to be either the director of the department's Office of Healthcare Reform, or I'm going to be the CMS Center Director responsible for implementing accountable care organizations, or I am going to be the Chief Technology Officer of the department, or I could be the CMS Chief Medical Officer. And I'm going to take a message back to the administrator that I was just in a room with 1,000 of the most brilliant minds in this country on quality improvement. And what did those 1,000 brilliant minds tell me about change? For 25 years, you've been responsible for change. You've been implementing change at all levels in your communities, in your states. You know how to do this. You've got some of the best methodologies, some of the best analytics behind you to make that change. You've changed OMB's mind just in one scope of work on the MRSA infection rate. So what I'm going to go back and tell the administrator is that there's a powerful change here. We heard the administrator say that you can't have improvement without change. You could have change without improvement, but you can't have improvement without change. And I'm looking at all of these quality improvement organizations, and I'm listening to them as though they are quality change organizations. And they're going to respond to those challenges that we have up on the screen.
Very good. Thank you, Deborah. You're in the idea of evidence-based practice, we're also developing new dimensions that really make things powerful. And we ask, that given like what you heard this morning, what's your best idea for involving patients? And if we did that, what do we expect would happen? Dennis, would you like to?
Yeah, very good. Thank you. Yeah, I had an experience 4 or 5 years ago, I guess now, where I had the opportunity to lead this large national breakthrough collaborative using the IHI model to increase organ donation. And when we started that initiative, Don Berwick was at IHI, and he made it a request of our leadership team that we involve patients. And we said, sure, we'll do that. And when we said sure, I thought we were saying sure because it was the right thing to do. That just makes sense, that we would do that. I didn't realize that when we began to involve these patients in our work, that it would transform the work, and that it would take us from incremental change to breakthrough change. But that is exactly what happened. And the kinds of things that I saw the patients that we brought into this work doing, at first it was very simple. We would invite patients to our meetings, learning sessions, just like this one. And we would have the patients present, and they'd chime in the breakout sessions, and they'd make comments from the floor, and they were just like everybody else. They participated. And then we started putting some of them on the stage to tell their stories, and oh my God, the kinds of things that began to happen. It's sort of like we're in the room, we're committed to increasing organ donation. We've got known best practices, and we have a PDSA methodology. We have all these assets that we could put to work. And then I'll never forget, there was a woman in Birmingham, Alabama, that we invited to speak on our program. And we did something there that was kind of risky. We'd never done anything like this before. In the organ donation community, it's very common to invite donor families, someone who lost a loved one that became an organ donor. And they sort of realize, like 6 months later, that it was the one great thing that came out of this terrible tragedy in their family. And they speak to it, and it's very powerful. Or it's not uncommon to have a transplant recipient talk about the gift of life and the fact that they went from looking like Frank looked 10 weeks ago to how Frank looks today. And it's quite extraordinary. But we invited this woman who was different. She was in neither one of those categories, and we found her in a very unusual way. she called HRSA on the 23rd of December, and I don't know what your offices look like on the 23rd of December, but in HRSA there aren't very many people. And she wanted to get permission to use this logo, this HHS logo on organ donation. We said, oh, it's in the public domain, just go ahead and use it. She's going to do some artwork for a charitable function. And she said, this group that I'm working with, they're kind of particular, and they need it in writing. So we said, okay. So we dashed something off, and we faxed it to her. I signed it. And she said, well, we need somebody from general counsel to sign it. And I'm thinking, it's the 23rd of December. We've already signed this thing. I mean, what more do you... That, well, I'll call Dave Benor, and maybe he's in. Maybe he'll sign this thing. Who knows? Sometimes GC signs things. My experience, it doesn't happen that often. But so called. Sure enough, he said, well, it's in the public domain. I said, so be easy, sign it. He's like, yeah, I can sign that. Great. So he signed it, and we faxed it. So Monica, she was calling from Fargo. So Monica, why are you so committed to this issue? Is there a loved one in your family that maybe got a transplant, or maybe your donor family, or maybe you know someone, that's waiting, and she said, my daughter, Alexa, died in July, waiting for a lung transplant, but a lung never showed up. So I'm doing this for all these other parents in hopes that this doesn't happen. And we were just like stunned. I mean, for someone to take tragedy, that's a tragedy. This 15-year-old girl, Alexa, her daughter, just a beautiful girl. She had photos of her because we learned about her then. So we got to know her a little bit better, and we invited her to speak at one of our learning sessions in Birmingham in front of a couple thousand people. And it transformed our community of practice. It really did. When we heard her, what she added was urgency. We had relevance and we had insight. But all of a sudden, we had something else, and it was an extraordinary asset. And we included her in many, many things after that. And just her story, that this is someone that has taken kind of the worst thing that could possibly happen to a parent and is turning it into a national good thing, is really extraordinary. So that's the kind of thing that I think comes from involving patients.
Thank you. Thank you, Dennis. When you look at those bold goals now, and you look at A, B, C, D, E, you see that you really have a lot of tools to work with, that this is almost a discipline in itself. How do we go into action to bring the right configuration of players together to achieve the goals? And the last two we asked you to comment on is, what action would you take by next Tuesday to start this? Because leadership is just talking, going out and talking and convening. And we ask you, what is a request or offer you can make to your peer organizations who would like to team with you? You never want to do this alone. And so you can get 2 or 3 or 4, 5 or 6 quality organizations in partnership on the same goal in different areas, working together to make all this happen. So what we'd suggest you do, make a request, is that you pick up that sheet of paper, this 60-second leadership response. It's 60 seconds because there's really only 7 statements. Well, if you check the goal off, 8. And in 60 seconds, you can give 10 sentences. So this is, if it's a sentence in every one of these, this is exactly a 60-second leadership story. And what we'd like you to do is, for the next 5 minutes, get the next slide, please. Fill it out as an individual. Or you can do it with a partner, but don't do it with the whole table or the whole organization, because we want you to do this fast. Fill out that one page, as many of those items as you can. Do it, work fast. Do it from your gut, this kind of blink thinking that Malcolm Gladwell talks about. When you're done, we'll ask for a few volunteers to share your answers, and we'll have our panel kind of reflect on what they're hearing. And this is really getting you ready to talk to the other executive panel on Thursday and really start to create a partnership with Don Berwick and his agenda, over the upcoming years. So you have 5 minutes. Could you all come back to the full group, please? Can you all come back to the full group? We have a couple of mic runners. Can I see the mic runners? Could you raise your hands? There's one mic runner. and there's a second back there. We have 2 mic runners. We'd like to hear from maybe 4 or 5 volunteers. And what I'd ask you to do is identify the bold goal that you think would be exciting in your area. And you don't have to give us all of these, but pick 1 or 2 and share with us the kind of readiness that you have, the kind of things you're excited about being in action on that goal. So can we have a couple of volunteers? Who'll be our first volunteer?
In my bag, I don't.
Your mic's
Over there?
on. Your mic's on.
Tell us who you are.
Rebecca Hightower, Louisiana QIO, EQ Health Solutions. We're one of the care transitions QIOs, and we've learned a lot in that project, and we've had a lot of success working with our providers. I'd like to see that expand to more communities, if not statewide. We've got tools, we've got strategies, we have change methods, we have providers who want to do it that have not been involved in the care transitions contract for the ninth scope because they were not in the designated community. Now we've shared tools with them, we've had some conversations with them, but we want to get out there and work with them.
So that's
and so 20% reduction in readmissions is possible if we can work with all of them and get everybody involved.
beautiful. I'm hearing both a request and an offer to spread this. Would you like to respond, Coach?
Yeah. Well, I would just say I heard 2 very exciting things in what you said. One is an assertion that it's possible to get 20%, which I think is extraordinary. The second is that you've got all these assets in play and all these potential customers waiting. I think that's fantastic. That is exactly what we want.
Say the 20% is possible, I think across the board. We've also been limited in the diagnoses that we can work with. But that's only a small part of the population. Even though they may be high-cost diagnoses, and we may have a lot of patients in those groups, there are a lot of other reasons that patients are readmitted that we have not even touched under the particulars of the contract.
Excellent.
So while we had success in that limited area, I think if we have a broader area to work with and more providers, I think we can have more success.
Excellent. Thank you.
Oh, over there. Tell us who you are.
Yes, Jenny Kitson,
Leave that to you.
Executive Director for the Network of New England. We are just beginning a project that has to do with the healthcare-associated infections, and I think dialysis patients are a very unique population because they do cross so many treatment settings and are in and out of hospitals, nursing homes, healthcare facilities, that the opportunity to reach out for new partnerships that are unique and beyond our usual customers and partners in terms of the dialysis facility is a wonderful opportunity to be able to work with reducing infections and to identify people that we've never worked with before, such as CDC and nursing homes, as well as people with the corporate levels who are now willing to begin to share information that they have internally, but give it to a broad-based organization such as a network. One of our assets, I think, is because we're patient-focused, they're willing to share proprietary information. And so this is a whole new opportunity that I think should be of benefit to patients as well as to the program in terms of reducing costs and care for patients.
Beautiful.
So what I heard was a definite proposal to do something that really addressed one of the bold goals here of healthcare-acquired infections in a setting that we're not currently or don't formally have a project in. So it's a new proposal to go forward to expand what we're currently doing. You certainly acknowledge the importance of the asset of the network, the asset of the trust that you have with the patient community and your ability to move things forward. So I think it was an excellent example of how we could achieve this bold goal, stating how, who, when, and a methodology.
Thank you. Go ahead.
Hi, my name is Andrea Goldstein, and I'm with IPRO, the QIO for New York, and we would like to commit to a 40% reduction in healthcare acquired conditions over the next 3 years. And we actually have a few partnerships that we think we would need to engage. One, the provider practitioner, but then also consumer advocacy groups. Within New York, we know that there are organizations, I think their name is Pulse. They are an organization of local parents who unfortunately have lost their children through healthcare adverse events. So we think that it would be important to include them in our partnership that we would like to be forming. One of the powerful assets that we think we could contribute is our reputation as a trusted partner, stakeholder in our state, as well as we're unique. We do have other contracts. We're not just a QIO. We already have existing contracts with the New York State Department of Health, Survey and CERT, so we believe that we would be able to leverage that as well. One of the most exciting change methods we would like to use is the idea of patient engagement, and something that we heard earlier today, the idea of creation of this culture of caring. That was very profound. We think that we could accomplish this work by working with community organizations, by using train-the-trainer kind of ideas, similar to diabetes education, training the community to then go out and kind of be our soldiers on the front. And the other idea that we thought was very exciting, and again we heard it this morning, was this idea of promotion of self-directed patient care teams, and that's something that we would be interested, again, and the reason why we would need the partnerships with our provider and practitioner organizations is to get them to embrace that idea as well.
Thank you. Wow.
So this is great. I love this one. And the reason I love it so much is it's really, really good. It's to the point, and it reminds me of me. So let me see if I can take it up a notch, though, because this is really what I learned from working with the executives and with Barry. As good as it was, in order to be effective on Thursday, it has to be shorter. It has to be much shorter, and it has to be punchy. And what I really liked was that you built on networks that you have now and emphasize, it's not just brand new from scratch, but you already have networks in place and you're going to build on them. The one thing I'd add to knock it out of the park is between now, which is Tuesday, and Thursday, go back to your existing networks, make a few phone calls, and in your presentation say, we've already called X, Y, and Z and X, Y, and Z over here, and we've got their commitment and we're going to start next week or something like that. Make the urgency in it.
Beautiful. I'm going to sort of cut off the feedback right now because of time, but what you've been hearing is that from the floor, you're hearing real campaigns evolving that can really address these bold goals, just what Don Burke was asking for. And I think our coaches are telling us Thursday, really go in and be very bold and very concise and very committed to the kind of relationships you want to build with CMS. Now, we have one more thing we'd like you to do, sort of a ticket out of the room, and I'll turn it over to Dennis to tell us about that.
Yeah, very, very good. Our last request of the day, unless you have other meetings after this, which you may have, I suppose. On each table, there is a one-page meeting evaluation for day one of our conference. And we'd like everyone in the room to just take 2 or 3 minutes and complete that one-page evaluation. And we have a team of about a dozen people that have committed to get together this evening, along with a number of us here on the stage. And we're going to review all of your evaluations. And in real time, we will try to accept your input and apply it to the work going forward. Dr. McGann is going to maybe like say a few words.
Yeah, I have a personal interest in this. At 8:30 tomorrow morning, I have to have assimilated, and obviously I can only do it with partnerships, all of the feedback you're giving right now, synthesized it, incorporated it into tomorrow's plenary, and feed it back to you starting at 8:30 sharp. So please do a good job, because we're going to be staying here with the volunteers and the partners and doing this tonight. So we really are taking this seriously. It's a rapid cycle exercise, and you're going to hear the synthesis of your feedback as best as we can do it tonight at 8:30 tomorrow morning. So this is serious, and please give us your feedback. Thanks.
Very good. And when you're done with the evaluation, just leave it on your tables, and we'll go collect them. There are about a dozen people that committed to assist us in the evaluation review this evening. And so instead of exiting out to the hallway, if you could come up to the front, if you signed up on that list, we'll get our plan together for quickly reviewing all this material.
Give our panel a hand, and thank you all for participating.